Oh, good afternoon, colleagues. Good afternoon. So I'm so sorry. I just had an impromptu meeting that I had to attend to. I'm sorry to be late. All right. So I am Carol Lord.
Good afternoon.
Yes, I wanted to know if I'm talking to myself, just as 13 persons on the Zoom.
Good afternoon.
All right, so let's just get to know each other quickly. We have 2 hours together, and the 2 hours can run out very quickly. So I'm Dr. Lord. I work at the Ministry of Health and Wellness at the Family Health Unit. So we would want to have some introduction. I was formerly in secondary care for the last, for about 13 years. Sounds plenty. So I'm now about nearly 10 years in public health. I did pediatrics for most of my life, and so public health is coming up quickly in that realm. Graduated from medical school from about 26 years ago. It's sounding very long when you start to call the years. Yes. So anything else you need to know about me? I'm willing. Right now, I'm presently the coordinator for maternal and child health with some amount of mainly for rheumatic fever, sickle cell disease, maternal and neonatal health at the Ministry of Health and Wellness. So I don't have your list of names, unfortunately, but I would like to know something about you, where you actually, your name, and why you chose MPH. Where you're situated. Huh? How many persons we have in the classroom? That is a familiar classroom. We will start with the class.
Hi, Dr. Lord.
Hello.
I'm Judy Hilton, and I did the MPH program so I can get a job because the job market is hard with a first degree only currently.
All right. So what is the first degree, Ms. Judy Hilton?
Biochemistry.
Okay. All right. And the other person? Nice to meet you.
Good afternoon, Dr. Lord. I'm Kay Parmaco from Victoria Jubilee Hospital. I'm doing the public health course because I think it will help me to be more efficient at my job at present.
Nice to meet you again, Dr. Palmer Cole. You need to speak.
Good afternoon, Dr. Lord.
Yes, thanks.
My name is Noreen Roberts, and presently I am the infection control nurse at the Spanish Town Hospital. And I chose MPH because of infection control and its in cooperation with public health. So I chose it to strengthen my field of practice.
Okay, very good. Nice to meet you. Next.
Hi, good afternoon, Dr. Lord. This is, oh, my face isn't coming up. It's Vanetta Johnson Hamilton. Ring any bells?
Sounds familiar. SPHN?
School nurses.
Okay, all right.
Yes, and
We
in
met at the Rheumatic
MPH.
Fever annual review the other day. Excellent.
Yes, and I'm in MPH to see how we can move school nursing forward.
Excellent, excellent. Mhm.
Hi, good afternoon, Dr. Lloyd. My name is Alia Ratri. I'm a patient advocate at the University Hospital of the West Indies, and why I'm doing public health with the post that I'm currently in and the previous one, I was working at Cheers, and I just grew to love the health field, and I just felt as if this was a good degree to go in that was very broad.
Yes, it is very broad indeed. I agree with you. Yes.
Good afternoon, Dr. Lord. My name is Cindy Pierre. I'm a community nurse residing in St. Vincent and the Grenadines, and I choose public health because I want to be more efficient, effective, and diverse within my field.
Nice to have you, Ms. Peart.
Good day, Dr.
Ms.
Lord.
Peart. Mhm.
Are you hearing me? Good day.
Yes, yes,
Yes.
Simone Doctor.
Yes. All right. So my name is Simone Doctor. I am presently a public health inspector assigned to the region under the institutional health portfolio. I chose the MPH program because I wanted to learn more about research and to see what type of research can actually be done in my field.
All right, you collected enough data for that. That's good. So tell me, which region you're attached to?
Okay, I'm with Southeast Regional Health Authority.
Southeast, okay. At KSA?
No, at the region. So it's the regional office by Dominica Drive.
Oh, okay, all right.
Mhm.
Welcome. Yes.
Thank you.
Alex Lawson.
Hi, good afternoon, Dr. Lord. I am Alex Lawson, physiotherapist within the Jamaica Constabulary Force. And the reason for me pursuing the MPH is to afford me a professional growth, as my ultimate goal is to be a part of the technical group that creates policy and procedures, particularly for our population as it regards to physical health.
All right, excellent. All right, nice to have you. We have Francine White Middletown. Yes.
Good afternoon, Dr. Lord. I am presently a grounds and landscaping manager. My background is in food quality. I have a first degree in agriculture production, food systems management. With a long time in food quality, it has made me become more curious on how to better facilitate preventing certain things from happening in the food industry instead of having a reactive system. Hence the reason I chose to do public health.
Okay. Nice to meet you. Food quality is very important at this time, right? Oshina, Noreen Roberts, Marcia Cameron Dawkins. We're just introducing ourselves.
Dr. Lord, I was the first person to introduce myself online. I'm Noreen Roberts. I introduced myself already.
Correct. You're the third, yes. Yes. You're the first online, correct? Yes.
Right.
Sorry.
Hi, Dr. Lord, can you hear me?
Yes, thanks, I am.
Hi, I'm Oshina. I have my background is in nursing. I was working as a student nurse. I chose public health because I have the desire to help people on a larger scale and to address health equity. That's my main reason.
All right. And what type of nursing you did, you said?
Aesthetic, cosmetic nursing.
Okay, thank you. Thank you. Nice to meet you.
Thank you. You're
Good
welcome.
afternoon.
Nice to meet you too.
Mhm.
Hello?
Okay, we have 6. Yes, please go ahead, Cameron Dawkins.
Yes, I'm actually in the theater, so I have to step away a bit.
All
Okay,
right.
good afternoon, Dr. Lord. Marcia
Thank
Cameron
you.
Dawkins, Nursing Institute, Spanish Town Hospital. See, I chose this program, one, because I have an interest in research, and I also love public health. I think it was one of my first love initially.
Mhm.
However, and I think I want to be a change agent in terms of our public health, the way our public health um, activities are going. So I'm trusting that I'll be able to make an impact in terms of research in the public health system. But as I logged on and I heard the voice, I said, "Whoa, that's all right, Dr. Lord," because I've been listening to all those the research and those presentations that you've coordinated so I'm looking forward to learn a lot and to try to make a difference in this area. Thank you.
Excellent, excellent. And you will, you will. All right. Who else do we have? Um, thank you, Sebastian.
Hi, Dr. Lord.
Hi.
Good afternoon, Dr. Lord. Right, this is me, Petra Williams Rayner. I'm the Manager of Public Relations and Communications at the Ministry of Health. And the reason I chose to study public health is because as a breast cancer survivor, I feel particularly invested in public health. And I therefore want to learn as much as I can in order to bring that to bear in the execution of my job at the Ministry of Health and Wellness.
Excellent. Thank you so much. Yes, nice to meet you again, my neighbor.
Okay, now.
All right. Have we? Cheryl Smith. Cheryl Smith, you with us?
Yes, I just joined. Good afternoon.
Okay. Good afternoon. Just introducing yourself, say where you're located, what you do, and why you chose public health.
Okay,
Recording in progress.
My name is Cheryl Smith. I work at the Kingston Public Hospital, particularly in the infection and control, prevention and control department. And that's where I got introduced to public health, and hence the reason why I'm here, because I want to have more knowledge in order to execute my job properly.
You fall in love with public health there. Very nice. Nice to meet you. All right. We have someone else in the classroom?
No, not currently.
Who is presenter? All right. I think we can move right ahead. Huh? We're missing 5 persons. Well, it can be 5. It will be about. two other persons who didn't introduce themselves. Okay, you have 1, 2. Okay, I'm 3 and presenter 4. So maybe it's just one other person. So we will move right ahead. So today, actually, we want to look at integrated approaches to local health systems for maternal and child health. And this is my baby, actually looking at maternal and child health. It is so important. You know, okay, some of you have not, well, you would have seen the picture, but I will just turn on my camera for a few minutes that you will see who's speaking with you, and then we will move straight into the lecture. I don't want any connectivity problems. All right. So when we think about integrated approach to local health system, all right, today we're focusing on maternal and child health, but tell me something. We have a pregnant woman. You know, when you think about maternal and child health, by the way, we're trying to move away from maternal and child health. Who can tell me why? Why are we trying to move away from the term maternal and child health?
Does it encompass the father?
Excellent. That is so true. And we need the daddies into the system. So I will not be saying maternal and child health very often, but that is it. That is the topic that we're dealing with today. Okay? So when we think about integrated approach, we have a pregnant woman, for example. She is about 32 weeks gestation, 32 weeks, 7 months pregnant. Please, I have to do the conversion in my mind, okay? For those who are not the non-medical persons. Okay, so she's about 7 months pregnant, and she has to go to 4 health centers to get the total care. What do you think about that? What are your thoughts about that? This is interactive, okay? She has to go to get blood investigations done at one location. She goes for the midwife to examine her at the next location, and then she goes to have her ultrasonography, right, Dr. Parmacol, done at another location. And this is what she has to do when she has to come to clinic. Tell me about that. What do you think about that?
Some
It's too
things are going to
bothersome.
be left out
Yes.
or not be done at the time when it should be done.
Yes, some things would be left out. That's exactly. And some things would be delayed. Yes. Someone else want to say?
The concept of going to multiple places might be a little bit tedious and a little discouraging, so resulting in things being skipped based on the perception that, you know, I have to be going all over the place to get these things done instead of going to one place.
And they may
Yes,
not have the
exactly.
finances either.
Finances, yes, because she has to get transport for all of these areas. Excellent, correct.
Inconvenient and a waste of time for the patients as well.
Waste of time, yes. And is it inconveniencing? Yes. Very much so. All right, those are very good responses. And so you find that we really have to have the integrated approach. This is what we call the holistic approach to health. Huh? Sorry, I didn't know I wasn't sharing the slides. So today we want to just define what is integrated health system and what's the role in the pregnant woman's health. All right, we want to analyze the challenges and some of the opportunities. We want to look at some of the policy frameworks and examine some case studies. And so that is one that I actually wanted for us to ventilate. But since we started a little late, we wanted to see what were some of her barriers and what are some of the strategies we can introduce to help mommy to have a holistic approach to her care. All right, so what is integrated health system? So we heard some of the feedback. So integrated maternal and child health approaches involve combining the multiple health services within a coordinated system to improve not only the health of mother, but also for the neonate and the young child, right? As it relates to immunization and all of these things. And so it helps to address the fragmentation that we will see when mommy had to go to all these different areas just to take care of herself and the baby. All right? So it's really to address, we want to know that it addresses the fragmentation so that we can have efficient service delivery, right? We want to prevent the fragmentation. If nothing else, when you hear integrated health system, you think to prevent fragmentation, okay? To improve outcome. So what are some of the outcomes we can have with this when we have this fragmented approach to healthcare? We heard some of the things the mommy psychosocial aspect can be affected because she can be discouraged. She only has passage to go and see the midwife. So the blood investigations and all the other activities will not be done at this time, you know? So this is we will go for 1 hour and then you will have a little stretch and then we will go for another, mainly it should be 45 minutes. All right, so let us see what is happening when we think about the framework on integrated people-centered health services. According to WHO, this is the World Health Organization. So what does this speak to? It speaks to engaging and empowering people and communities, to strengthening governance and accountability. And someone made the suggestion that some things would be left out. And so whose responsibility will that be? When she has fragmented care, where would you say who will be accountable? Is it the midwife at the health facility? I want to see some actions in the chat. At least I can't even see the chat here.
That's the same problem.
Sorry?
That's the same problem.
Yes, it's a system problem. Excellent. That is a system. And that is why we have to, by all means, have the integrated approach. Because who will then be in charge of where she belongs to? You know, who will then be responsible for her? Who has the ultimate responsibility? And that's very important. We talk about, and so that is why there is the big thrust on having the reorientation of the health system, all right, so that we can have mothers and children and fathers, as we think about family health, having care homes, and hence the reason for health centers. The health centers are in the closest proximity to the patient. And so with those health centers, the family is able to access care. It's accessible, you know, It's available at the health centers. All the health centers are staffed with healthcare workers. And so if there's any challenge, there is also the possibility of referring to another institution. So we will look at also as the coordinated approach to the health system here in Jamaica. And we'll also look at maybe 2 other countries once time permits. So when we talk about coordinating within across sector and creating an enabling environment, the enabling environment means that we want to ensure that everyone knows Miss, let us call her Miss D. Everyone knows about Miss D and knows where she is in her pregnancy, what is needed in her pregnancy. And so that's very important. Yes, I heard not the midwife, the system. Right, I see that. Yes, it's not the midwife, but it's the system that is that we need to be working on. In the first place, we need to have systems in place to take care of Miss D and her pregnancy. Okay. So we look at the importance of integration, and we had some of the responses there for the importance of integration. We have it reduces maternal and neonatal mortality because we can know through timely interventions if mother needs a cesarean section now, she needs to be admitted for induction. That is important. It integrated system, family health services offered to mommy will ensure comprehensive antenatal, perinatal, and postnatal care. But no, when we have an integrated system, it helps to take the person, Ms. D, across the life course. All right, you know, that is the other buzzword. When we look at patient-centered approach or people-centered approach, we look at the life course. So who can outline to me what the life course is all about? Can someone share with me what's the life course? When we talk about life course, what we're talking about? Not all at once, please.
The life course is from birth to death.
Sorry? I didn't hear that response.
I was asking if you're speaking about the course of life, meaning from birth to death.
Yes, yes, yes. From womb to the tomb. Yes, that's what I'm speaking about. So it means that this integrated approach will have preconception, where we have intervention before mommy gets pregnant. We have intervention when she gets pregnant, intervention during the pregnancy, intervention during the delivery. Then we move when we then go into a separate area now where we're looking after mommy. Mommy moves into childhood, her adulthood phase, and the child now moves into immunization. So we start with the child, we move into immunization, ensuring that the child has good nutrition, because good nutrition means that mental health and brain capacity would be improved. All right. So the life course is important because then mommy will become an elderly. And then we have the advanced maternal age. Hopefully that we avoid the advanced maternal age if she has a second pregnancy, but we would want her to age gracefully. And coming behind is the neonate, and we want to have a healthy neonate coming following mommy's footstep. Okay, so in integrated approach in maternal and child health, increase accessibility and coverage. It also helps the efficient use of resources and strengthen health system. So when we talk about increased accessibility and coverage, it brings the service closer to the patient. She doesn't have to think about transportation cost if it's just down the road. For example, in Jamaica, we have about 324 health centers. You know, Jamaica is known for church at every square foot. Right. We have many health centers that parents and children have access to. And so that is very important, improving coverage. It reduces barriers to accessing specialized maternal and child health care. What do we mean by that? Mommy has sickle cell disease, for example. What would be her trajectory? Mommy has sickle cell disease. What would be her pathway now? She was first a regular pregnant woman, and then in the blood investigations come back, and she's now sickle cell positive for HBSS. What will happen to her then? What should happen to her?
It would be
Yes,
sorry.
Go ahead,
Someone
Cindy.
else is talking. But it would be an integrated approach between the obstetricians, gynecologists, maternal fetal medicine specialists, and the sickle cell unit, as well as her regular medical practitioners, to coordinate her medications, the pros and cons and risks to the baby, and balancing the pregnancy.
Excellent. So she will now have to go to high risk. Sorry, go ahead. I thought you were finished. Go ahead.
No, it was just Cindy. I was
Archer?
saying the nutritionist would have to be involved as well.
Excellent. Thank you. Thank you, Ms. Pear. Yes, we must have the nutritionist. Yes. And welcome, Ms. Archer. So you understand? And so with this, she will not now be at the low level or the level 1 primary healthcare health center. It means that she has to, in order to access a specialized care, instead of telling her, okay, you will come at our health center, the type 1 health center, and we will try to manage the baby. And then you go to the hospital to see the specialist. And then you come back to us and let us know what the specialist has said, that we can do the intervention. So it's not like that, because we want to encourage her to also be closely monitored during the pregnancy for favorable outcome. Okay? We speak about the efficient use of resources. And someone made mention, we want to reduce duplication of services and optimize care. She must not be seeing the same, coming to the health center for the same thing and then going to the hospital for the same thing. We would normally do co-management. The co-management is that not, for example, as a high-risk patient, she will not be going every week to the hospital and every week to the health center. But the health center will keep tab of mommy just to ensure that she maintains her appointment at the hospital. Because remember, the health center is the foot soldiers for care. So they have to ensure that mommy keeps all her appointment at the high-risk clinic, and they will ensure that mommy has her medication. The community health aide will visit her, so she doesn't have to be going at both sides, because we'll have overcrowding at the health center and overcrowding at the hospital. All right? And someone made mention of the cost, the finance involved in the process. So it's important that we have this integrated approach to care. It's important to integrate care because it encourages multi-sectoral collaboration. And Ms. Pear rightfully said that she needs to see the nutritionist. You see, we have the nutritionist here. And if she has 5 other children and have poor housing condition, she really needs to have the social services involved in the process. Okay, and so we have the, yes, go ahead. And so for the maternal record book, every mother is screened for these areas. Huh? This is a patient health book. We will come up to it shortly. Let us move. And then integration helps in data collection. We have persons who's Simone Doctor, important in wants to know how it can make her data speak, doing public health to make the data speak. And remember, data has to guide what we need to do. And so data helps us to have better policies, form policies that will help the process, okay? So if we don't have data, we really can't have a policy. We don't know who is affected, who this intervention will enhance. And so that is important. Let us go and lastly, we say to reduce the need for multiple hospital visits by providing comprehensive care in one location. All right, and we expounded on that, and we say it enhances trust in the health system because we have accountability, leading to higher service utilization. So let us look at the mortality rates. Oh, when in the break, I will pull up that slide on the mortality rates and show you what has been happening with the mortality rates. All right. But it's also important that integration has an impact on these important indicators, the maternal mortality and the neonatal mortality. And so it affects the country's data. And that's why it's important that we have an integrated service. When you want to know how well a country is doing, you can look at the neonatal mortality or the maternal mortality of that country. And it says what is happening with the population as a whole. And so that is why I believe our colleagues say, well, listen, let us look at maternal and child health specifically because we have adolescent health, huh? We have adolescent health, we have the other elderly health. And so the other areas will look into these, to those aspects. So let us look at what's happening with Jamaica. We have primary, secondary, and tertiary care in Jamaica. Primary care, they are the health centers. And as I said, we have 324 of them. Remember, in Jamaica, it's just about, we have about 2.8 million population. So what is your population like, Cindy Pear, in St. Vincent?
My population is very small. I think about around 110 to 120.
120,000?
Yes, please.
And how many health centers you have there?
17.
17. Okay. Excellent. So tell us some more about your health system there.
My health system is similar to the rest of the Caribbean in terms of delivery of primary health care and services, integrated approach. As I said, we have the health centers itself, then we have few districts, hospitals, and polyclinics that help to take the burden of the primary healthcare centers itself.
All right. So, what is the difference? What different services do you offer at your polyclinic compared to your health centers?
The polyclinic is like more of a hub where you have a doctor every day as opposed to the primary health center that has doctors day like once per week, and it's open 24/7 as opposed to the primary health care center where it would open from 8 to 4.
Ah, all right. Excellent. Excellent. Who want to share something about Jamaica's health system? The primary health care. We run primary health care right now. All right.
And I
Go
forgot
ahead.
to mention that with some of our primary health care centers, they have a nurse that lives on the compound in government-funded facilities to provide 24-hour service to the community in which they are assigned.
Excellent. That is great. That is great. Is that the nurse is a midwife, or is it a community health worker?
In some instances, we have single trained nurses, and where we can, we have midwives.
Excellent. All right. So we have the example of St. Vincent and the Grenadines. So can we hear something about Jamaica? Can someone share with Ms. Pear what happens with our primary health care? Cheryl Smith, you want to tell them something about our primary health care system? What happens when we go? What happens when persons go to our health centers?
Well, let me see if I can help.
Yes.
This is Web McBean.
All right.
So in
Web
terms of
McBean,
our
you
primary
just
health
came.
care,
Okay.
we have health centers ranging from type 1 to 5. All our health centers offer maternal and child health services. However, for the type 2, type 1 health centers typically don't have a doctor there at all. And so patients would have to go to either the type 2, another facility within the zone to be able to see a doctor. In terms of typically, for the most part, type 2 may or may not have a doctor every day, but all the type 3s up to type 5 will have doctors every day. There are some health centers in which there is a specialist based or a specialist that comes particular days during the month. And there's usually a schedule that says, okay, the obstetrician is here on this day, they can see gynae on this day. And typically, the patients are seen at least once by a general practitioner, who is usually a doctor based at the health center, at least once during the pregnancy, to have a general assessment. And for booking services, they'll usually see the obstetrician. And if there are any challenges, the obstetrician would also be the referral point. If there's an obstetrician based in primary care, and then there are other patients, depending on what their issues are, that we may refer them directly to the hospital.
Yes, thank you. Thank you very much, Nurse McBean. I see you're in KSA. Nurse McBean?
Yes, I am.
It's Dr. McBean.
Dr.
Lord.
McBean, I see you're in.
Yes.
I see you're in KSA. The minute you speak to obstetrician in primary care, that's Kingston and St. Andrew. So very good, very good. All right.
Plans
Go
to get
midwife
here in the other parishes outside KSA anytime
Sorry?
soon? No, I was wondering if there are any plans to get obstetricians in the other parishes anytime soon.
Yes. Yes, that is the plan, and that is why we have the primary care initiative by the chief medical officer. We will have those obstetricians. They will increase the number of obstetricians at the Type C hospital. You're speeding us forward. Yes, we're going to increase the number of obstetricians at the Type C hospital, and they would be covering the health centers in that area. Normally the high risk clinic for those who are the high risk persons are those who they have a pre-existing condition in addition to their pregnancy. For example, they may have a non-communicable disease with the pregnancy, or they may not have any NCDs with the pregnancy. They may even have, for example, what we will call incompetent cervix. And so they would be considered a high risk person. And so at these health facilities for the high risk
High
pregnancies.
risk by myself.
Oh, congratulations.
Yeah, I'm high risk always.
Oh. Tell us, Sam, you want to share something with the team about that?
Yeah,
What
I
may
have incompetent cervix. So every pregnancy I'll have to have cell clutch placement, bed rest, and all my deliveries were premature deliveries. So I had a miscarriage twin at 20 plus weeks. I also had my son at 34 weeks, and my twins, my second set of twins, they were born at 31 weeks.
Wow. So thank you so much for painting that picture for us. So imagine I didn't even think about that, but I'm happy that we had someone. Most often when you think about the high risk clinic, thank you so much for sharing, Ms. Pear. When we think about the high risk clinic and high risk patient, person's mind move into this person must have a high blood pressure, or diabetes, or sickle cell disease, or some SLE or something within the pregnancy. But we want to say that is not the only criteria for being high risk. And so, as Dr. McBean has actually pointed out, there's different levels of care as we move from primary to the secondary to the tertiary care. And as Dr. McBean has indicated, the different levels in St. Vincent that has been, Ms. Pear has been saying the different levels, the polyclinic and the primary healthcare clinic. And I do know of some countries that they actually facilitate the resident midwives within the community, so that if there's, especially those communities that are far away from a hospital, here is where we have the basic emergency obstetric and neonatal care being offered, or within the hospital where we have the comprehensive emergency obstetric and neonatal care offered. And so if you notice, the health system is very much in the integration. I believe the Caribbean has really done very well on the integration process, in offering care and have patient-centered approach and not disease-centered approach. Just imagine mommy with the sickle cell having to go to the NCD clinic to manage her sickle cell, has to come to the primary care area to manage the pregnancy, having to go to another location to have her investigations done. You understand? So I like how you started off saying the challenges that can occur when there's no integration of services. So I hope you have a comprehensive picture of what primary care what happens with the structure of primary care and the health centers and how it works to give a holistic care to the mothers. We have facilities with midwives only, and those can be close to the resident midwives that we have in St. Vincent and the Grenadines. We have the type 2 health centers that we will have doctors going once or twice per week. And then remember, during the pregnancy, one thing I want to say to you, to everyone, just remember, during the pregnancy, it is mandatory, it is policy that the pregnant woman must see a doctor during the pregnancy, high risk or not. All right, that is one of the policy. Ms. Pear, that is one of the policy we have here in Jamaica, where the
We have
pregnant
the
woman
same
must be
policy.
seen. You have that too?
Yes, please. And we also have an obstetrician that comes out to the community that we can do referrals instead of overcrowding the outpatient department at the hospital.
Excellent. And that's what Dr. McBean made mention of. And that is why we have, to decrease the overcrowding at the hospital, we have a primary care obstetrician gynecologist that will do the clinics at the various health centers. This obstetrician moves from one health center to the other with specially referred patients, where they see specially referred patients from the midwives or the family nurse practitioner. All right.
Yeah, and we have also decentralized radiographic services such as X-rays and ultrasounds. Only thing we have not reached with is the lab services, but we get there.
All right. Anyone want to say to Miss Pear what happens with the lab services? We do not have lab services at all our health facilities. But can someone share what actually happens with the laboratory services? As we in Jamaica, I think, is one of the very, very good integrated service example. What happens with the lab services?
We don't necessarily have labs at each facility, but we have the lab personnel will usually come and take off the blood at the health center. So they usually have the first antenatal visit. At that visit, the lab personnel is also there and they'll take off all the blood. So the person does not necessarily have to travel to a different health center to have their blood taken. And then the results usually goes back to the health center.
Right, excellent. So this is preventing mommy from going to the lab. We have the phlebotomists that will actually, we call them the LTAs, lab technician. I can't remember. But they would actually come to the health facility. So whenever there's antenatal clinic, and then we have a schedule. Each health center has a schedule for the antenatal clinic. So when it's antenatal days, different from the curative days. The curative we call the NCD days, right? The non-communicable disease. And then we have the well child visits at a separate day, you know. So when there is the antenatal clinic and the NCD or curative clinic, we have these laboratory technicians that will actually go to the health facility, take off the sample, so mommy does not have to go to the lab to get the samples taken. And as we are on that, we also see similar process with the pharmacy. With the pharmacy, we have dispensing done. We have mobile pharmacies that will go to these institutions, that if there's medication that needs to be prescribed, mommy doesn't have to move and go to the pharmacy, but the pharmacist will come with the medication to the facility. So that is all happening actually, just to offer the integrated approach. So do you have an idea now of why we need the integrated approach, team? Colleagues?
Yes.
All right, Alex, what are your thoughts? Alex Lawson.
So my thoughts on the integrative approach is that it's well needed to optimize the delivery of care, as well as a continuity of care throughout, serving the clients, as it would limit wastage, a waste of time, and overall optimization of service.
Yes, thank you. And what are your thoughts? What are your thoughts, Alia Rattray? Alia Rattray? You have a clear idea now of why we need integrated approach to care? Miss Rattray? Miss Rattray is not with us? All right. So before we move on to that, let's look at what happens with secondary care. Who wants to tell us what happened with our secondary care? How do we see integration in secondary and tertiary care?
Through adequate referral systems.
Yes, referral, excellent. Yes. So it means that we have to have our specialists within this higher level of care. Know that the secondary and tertiary care is a higher level of care, more specialized care that Miss D, who is pregnant, will need. All right. For example, we have few parishes here in Jamaica that still will conduct home deliveries. But when we speak about secondary and tertiary care, you must have the specialized hands, all right? Trained hands to have the deliveries. Not to say that when they do the home deliveries, it is not trained hands, because the midwives are trained for delivery, because most often it is the midwives who are at the health, it's the midwives who are at the health facility at the hospital that actually some of them will do the community deliveries, like how you have the midwives within the primary care at the home services. They will have those. So what we find is the specialized care. We want the skilled deliveries, and that's what's very important. Okay. So we now move straight into the regional health authorities. I wanted to do the whole area of, you will get the slides, the whole area of the introduction of user fees. And when we saw the primary care model in the 1970s, and the Declaration of Alma Ata, you can imagine how that was a big intervention for healthcare within the region. All right. And so when there was this declaration of the Alma Ata, at first they said, well, listen, mommy's saving passage or daddy is saving passage, transportation from moving from point A to point B, we can have user fees. Instead of spending that money in transportation, it can be given back into the system. So they had the introduction of user fees. So how many persons are very happy we don't have user fees right now in Jamaica? Let me see a raise of hands. I just want to ensure you're not sleeping on me.
We are awake. We're hearing you loud and clear.
All right, Ms. Archer. All right, I see Alex, yes. I don't see any more hands in the chat. I'm stopping to look in the chat to ensure persons are with me. All right. So the important thing is, with the abolition of user fees, it actually helped care to be more diverse, and that is why we said that the care is taken to the patient. All right. In 2007, we had abolition of user fees for those that were on the 18 years, and then by 2008. So this very day, we have no user fees at all. All right. And this is one big intervention that everyone be able to have access to care. And so we did the profile of Jamaica, knowing that it's an upper middle income country. And this is where we have the details of Jamaica in terms of the Jamaica. Remember, we say we have the health centers. Well, the health centers are scattered around these parishes. These are the parishes, 13 parishes. All right. In Jamaica, we have the Kingston and St. Andrew. The green represents hospital, where we have the hospitals there. The green represent the hospitals. The yellow represents the hospital. We have regional hospital, where the green are, we have regional hospitals. So the yellow and green here, if you notice, we have private hospitals on this system also. So we have the 4 regions in Jamaica. We have the Southeast, we have the Northeast, we have the Western region here, and we have the Southern region. So each region has about 3 to 4 parishes. All right, so like the Southern region, we have 3 parishes, but like the Western region, we will have about 4 parishes, which is Savlamar, Hanover, Montego Bay, and Falmouth. And you know, this is the area that was impacted with Hurricane Melissa. So most of the interventions are there. Okay. So when we look at the health system, though, as one person has highlighted, that it's not really the persons. You have to look at the health system. We have to cause the system to be responsible. So for the system, we have to ensure that there is sufficient physician or midwife to population. That's one area for us to be able to ensure that that is intact. And so here we have the proposed midwives, the proposed midwives, the proposed physicians in primary care, and the proposed physicians in secondary care. And with the primary care model initiative, this is what the numbers should be, the proposed numbers. For example, in secondary care, they propose that when we have this introduction of the primary health care initiative, we should have 2,697 physicians in secondary care, and that cadre should be able to take offer health to the population, the 2.8 million. We presently have 1,443. And so, for example, when you look at the midwives, it says what is the proposed number and where we plan where those posts are being filled. So this is one area that we have to be looking into to prevent duplication of service, because we do not have healthcare. We do not have the healthcare workers to have duplication of services. So integration helps with this distribution of healthcare across the board. Let's look now. Let's have a look here at the structure of the health system here in Jamaica. If you look at the top, we have, we have the Ministry of Health and Wellness. And for the Ministry of Health and Wellness, we have the permanent secretary. Hold on, let me see if I can have the. Good. We have the permanent secretary, the accountable officer. Here's where we talk about the governance of the health system. All right, because we cannot speak about integration if there's no governance. And as someone said earlier when we started the session, that Ms. D, this antenatal mother, she would not have been assigned to anyone because everyone will say, okay, that other person will be taking care of her. And so the permanent secretary is the accountable officer for the Ministry of Health and Wellness here in Jamaica. Okay? And so we have the ministry divided into several arms. This is one of the older organogram for the health system here. This has since been updated 3 or 4 times, but there's still tentative posts, positions that we have to be looking at. And so when we think about the permanent secretary, we have the different branches within the Ministry of Health and Wellness. Health form under the technical division. And under the technical division, we have several branches. All right, so we have the permanent secretary, his administrative head. And for the technical division, we have the chief medical officer and the chief nursing officer that are responsible for the doctors and for the nurses. We have several other divisions on the branches under the technical division. We have, for example, the Health Services Planning and Integration branch. And for the Health Services Planning and Integration branch is here where you have the Family Health Unit, of which I'm a part of. We have the Mental Health Unit. We have the Physiotherapy Unit, right, Mr. Alex? We also have after the physiotherapy, we have the radiology section of the services being offered. And so we have the health services, the monitoring and evaluation section. And these all fall under health services planning and integration. We also have the other branch that we call the health promotion and protection branch. The health promotion and protection branch is where, Simon Doctor, the public health inspectors come under that branch. So that's where we find the public health inspectors, the health promotion officers, health education, health promotion officers. We have the non-communicable disease coming under this branch. This is a very large branch at the Ministry of Health and Wellness. And then we have the National Surveillance Unit, the Epidemiology branch. And there's where you, more of the research, Simon Doctor, when you're thinking about it, you know, here is where they zero in on researches. Here is where we have the reporting of diseases so that we will know when there's an outbreak. And if you're looking at the news, it will tell you when there's an outbreak and when there's not, because we have what you will call the epidemiological threshold. And once we're above that threshold for some diseases, it will tell us, well, listen, we have an outbreak. And so the reporting mechanism and the governance is very important as we think about the integrating the system. All right. When we look a little deeper on this is the technical division. I just went to the details, but the other units and the other branches, divisions that we have at the Ministry of Health and Wellness, we have the legal division, we have the public relations and communication division, of which we have our manager, Mrs. Petrie Williams Rayner. You want to tell them something about that division, Mrs. Williams Rayner? My neighbor.
Sorry, just to say that the Public Relations and Communications Unit forms a part of the Executive Management Branch, which is where the PS side of things comes in. So corporate services, PR, as you said, international cooperation in health, etc.
So how do you function with the integration? How do you help us along the way? I'm just asking you what we will normally do.
Well, communications is the core of everything, if I may say so myself. And so in terms of managing relationships among our internal customers, so all of the set of people that you talked about there now, Doc, who form part of the org chart, as well as our external customers, the people we serve, both in terms of our regional health authorities and others, we're that essential linchpin, as it were, working together, of course, with our health promotion and education folks over in the technical services branch.
Yes, all right. And so once we need any communication, you finish? Sorry.
Yes, no, you can layer on, Doc. We are here to provide that
Yes.
service
Thank
for
you
you.
very much, Mrs. Williams-Rayner. So she knows that we come to the branch to that division very frequently for the request when we want communications to go out. That is very important, because we need to communicate. For example, we're having some maternal health outreach at this time with the hurricane impacted parishes. And so communication and collaboration with the public relation and communication division is very important. All right.
I think just
We
to
can
say as
go.
well, Dr.
Yeah,
Lord, that you talk about the integrated approach. Without the various teams working together, it is not possible for us to do the communication effectively. So we need both sides of the pie, the technical folks, which is largely our clinical teams, together with our other service providers and our regional health authority stakeholders to be collaborating alongside us in order for us to do the work that we do and to do it well in the public health interest.
Excellent, Mrs. Williams-Rayner. Thank you so much. And you remember she made known of one reference. She said the regional health authorities. You see the regional health authorities here, right at the top here. We also have the National Health Fund that also form part of this integrated approach. And so the National Health Fund is where they have the drug serve at the various pharmacies, the various health centers. And with the drug serve, that's how we have the mobile pharmacies also. And they have really made life easy, not only for the patients, but also for the healthcare personnel. All right. This is the section that I actually went into detail with the chief medical officer and the different branches, the epidemiology branch, the health promotion and protection branch, the health services planning and integration, of which we have the various family health units as well as mental health. And then we have the emergency, disaster management and special services. That's the EDMSS. They're very busy. Once they're the command center for the Ministry of Health and Wellness. Whenever there's a disaster like Hurricane Melissa, they're the ones who will say how we integrate the systems so that the country will still continue to function. All right, you may have this as another lecture sometime. All right, within your scope. But let's move. I notice we're going. And this is what we have as a family health unit right now. We have the director of family health unit. We have the administrators, the secretaries, the program development officers, the program officers, the adolescent health coordinator. And so if you notice, this cannot serve the country. So we have another proposed way in which we plan to offer care in this holistic way, this integrated care. All right. So at this time, I will just pause that you can have a 10 minutes break. Is that okay? Then we look into the roles and functions of the regional health authorities and Ministry of Health and those sort of. So we return at I have 3:27 now. Can we say 3:37? Please ensure you move, huh? Please ensure that you stretch and you move. If you don't have a bathroom break, you just ensure that you do some stretches. Be on Jamaica moves. Presentation tomorrow. It's a waste to go. Just fit a communicate. Especially if the Christmas tree, she have a try to get tomorrow. And tomorrow that's someone like no wish she had the tree up. Where she had the tree, where not is fun, is it child? So Santa is there.
Remember the doctor from four different from orange.
Exactly.
Remember she come here with one of them from one of the doctor who did the presentation when we had the something there, the workshop. Yeah man. She came with one of the doctors. Yeah.
Okay, thank you so much. Hope we're all back. Are we all back?
We're here,
Yes.
Dr.
I'm
Lauren.
here.
Excellent. Okay, we have online and we have in the room. So we continue. Any questions so far? Any questions? Anything you need clarification on? All right. Silence means yes. So what can I give you clarity on? All right. So we will continue here where we left off. So we're speaking about the health system and the accountability that has to happen, the governance and accountability that has to happen for integration to work well. And so we went through this this scenario where we went to the where Miss Pear and Dr. McBean was able to tell us about the health centers, excuse me, and the hospitals, and how we were able to have the proper referral system so that integration can be achieved. All right, this is the Jamaica health system with the primary health care approach, where we are trying to ensure that we have these care homes, right, for patients to be able to visit. We have the type 1, 2, 3, 4, and 5 health centers. Oh, let me show you what that looks like with the reclassification. Let me stop sharing. If I had to share it, you would not have been seeing. So this is what the health facilities look like for with the classification. This is for Jamaica, where we have the type 1, 2, 3, 4, and 5. You can see my screen. The type 1, 2, 3, 4, and 5 health centers. We have the community health centers. This is this is the reclassification here, where the type 1 and 2 health centers, that is the one that has only midwives, and one that we have doctors visiting only twice per week or once per week. They would be classified into the community health centers here. So these two will be classified into the community health centers with the reclassification. The type 3 health center, where we have doctors there nearly every day. It would be the district, known as a district health center. The type 4, where we only have 7. No, the type 4 health centers are really facilities that has a hospital on the compound. So who can tell me examples of type 4 health centers?
St. Jago Park.
Yes, St. Jago Park. Should be a 4, but they don't call it a 4. They still call it between a 3+ and a 4. Yes. Whereas we have the hospital and the health center on the same facility.
I think we have one at Falmouth, Doc.
Trelawney, I'm hearing Trelawney, I'm hearing Falmouth. Yes.
St. Mary.
St. Jago Park. But the person said that they don't function as a type 4. Yes. We're coming down the list. We have the list here. Moranbe. Do you see Moranbe?
Yes, Moranbe, yes.
All right. So you see, when we come down this list, it tells us all those who are type 4. Yes, I know this has been one of the trick in the health system. Why type 4? Sometimes they don't offer all the services that that should be there, but it's all because they're type 4 because they have a hospital at the at the area. Look, you see the Farmouth. Someone said Farmouth just now. Look, Farmouth is right here in Trelawney. You realize that they try to have one at least per region.
Yes.
Lucy, anyone said Lucy? I didn't hear Lucy. There's one in Lucy and there's one in Port Antonio. Port Antonio, that's familiar. Anyone from Northeast here? Sorry?
Port Antonio is a type 4 health center because
Yes,
it's not an hospital compound. They're across the road. No, they're not across the road. They're quite a good distance. One of them.
yes, it sounds very strange, right? But I guess it's from the original situation where it was, the location where it was actually classified, and that is why they have actually been able to change that around. Look, you even have here where I saw that St. Anne's Bay. We know the health center is nowhere near the hospital right now, but the St. Anne's Bay Health Center is considered a type 4 according to this classification. And this is the most recent classification. We haven't had any changes to this since. All right. So that I just want to raise your awareness to the type 4 health centers that we have across the nation for a particular reason. Let's go back to our presentation now. Good. So, and we were looking at the type A, type B hospitals, type C, and the specialist hospital. Who can name me 2 specialist hospitals? Not Dr. Palmer Cohen.
National Chess and
National Chess, yes, Mr. Alex.
Victoria Jubilee.
Victoria Jubilee, yes.
Bustamante would be a
Bustamante.
specialist one.
Excellent. We're on the go. Excellent. Right. 2 type C hospitals.
Black River.
Black River, yes.
Lionel Town.
Lionel Town, yes.
Port
Noel
Maria.
Yes, Port Maria, Noel Homes, yes. All right, so we just have a few minutes. Let us just move on. So you just have to make yourself familiar because of the integrated system. You need to know where you can refer and where you cannot refer. All right? So that's very important. So when we look at the role and functions of the Ministry of Health as well as the Regional Health Authority, they really have similar roles. But remember that the Regional Health Authority is a autonomous body. They have their whole system, all right, and they make their decisions. So when we look at the Ministry of Health, we have the policy function, we have the health regulation, healthcare regulation and oversight, we have the partnership, and with international relations. Remember, Mrs. Williams-Rayner was speaking about our internal and our external partners. Okay, disease prevention. When we were looking at the organogram, we saw the EDMSS, the Emergency Disaster Management and Special Services. And so they actually initiated response to any threat to the country. Okay, and we have our data management system. So we also find, okay. And we also find similar roles and function within the regional health authorities, the 4 regional health authorities for Jamaica, but they do not make policy. All right, they implement the policy. The development of policy is only at the national level. All right. So they also have the data. You can look into the details of these individual areas. All right. So when we talk about the regional health authorities, we were looking at them in the table just now. We have the southeast, the southern region, the western, and the northeast with the various hospitals. Remember, we should have. They have 23 hospitals here. One is missing here. So we have the population that is served. Sarah serve about 47% of the Jamaica population. And so it has most of the tertiary institutions. It has is the referral hub for the country, for the island. Okay. Followed by it's not one missing. It is one addition. University Hospital is not part of SARA, as most of us may normally place it on the SARA. Remember, University Hospital is a semi-private institution. All right, and it doesn't come under any regional health authority. So that makes it 24 hospitals across the nation. All the others fall under the regional health authority or as private entities. What does it mean? That they receive subsidy from the ministry from the Ministry of Health and Wellness to assist in functions of the health for the nation. Okay. So what do? We follow the Vision 2030. I would want you to look more into detail for Vision 2030 and looking at the framework in which integration can occur, whereby we want to be able to manage. And these were the suggestions that we had when we first started this session, where we have the service delivery, right? We have the workforce, managing health information system. Okay. Health financing is very important, and governance. Those are those are the foundation and the building blocks on which we manage the integration. So when you're looking at a system, then when you're examining a system, these are the pillars and the framework that you should look at to know whether the integration is complete or not. The other area that guides our integration process is the Vision for Health 2030. Okay. And this is a 10-year strategic plan for Ministry of Health and Wellness. We have it online. Okay, that you can look into the details that help you to understand more of what this integration is all about. In addition to that, we have our Vision for Health 2030. And we really want to increase and improve health financing for equity and for efficiency. So integration is important in that process. All right. We want to prevent duplication of services. I just remember that we're finishing at 4:00. Sorry. This is one area I want you to get familiar with as we look at not only at the national level and at the regional level, but you should be doing this at the parish level, where we, for the integration, we have to work with what you would call an operational plan. It states which unit is doing what, by when, and how. Okay? It tells you if you're achieving your target or not achieving your target. Okay? So here is where it has this is one, for example, for the family health unit. This is a few years ago, I think it was 2 years ago or so, whereby we look at what are the strategic objectives we want to achieve. And the strategic objective is really as part of the Ministry of Health and Wellness, okay? And with that strategic objective, it means that the different divisions, the different units would be doing, and the different divisions will be doing various activities. For example, for the maternal and child health, for example, we spoke to developing guidelines. Okay. The development of guidelines. For example, the development of guidelines. Why do we need guidelines?
Consistency, continuity, and sustained quality, doc.
Excellent. Thank you, Mrs. Williams-Rayner. All right, we need guidelines for consistency. We don't want that management in Kingston is different from management in Westmoreland. All right, it helps to standardize care across the parishes and across the nation. And so this is what we would like. This is one of the major activities we will have if we want to develop and maintain standards for secondary care from facilities in keeping with the international best practices. And so the key output was that you have to produce the guidelines, for example. And so it says that where we're starting from and where we plan to go within the 4 quarters of the year. One area I want to make known to you is that we would normally think the year, it's Nurse Vonette Johnson Hamilton, we will say the year at school will be from January to December. All right, but in public health, we speak about the fiscal year. The fiscal year starts from April 1 year to March the following year. And so that is how the quarters are divided. I remembered when I was finished with my MPH, when I did my MPH, and I went to the health center. I was at Glen Vincent Health Center at one time. When I went to MPH, I went back to pediatrics. I continued to do pediatrics for some years thereafter. But when I came into public health and I was when I moved to Sarah, Dr. Magdalene, that's how I know you were talking about Sarah. I spent years at Sarah. So when I move into Sarah, and they told me about operational plan, I said, operational who? All right. So I thought that even as I was, I just decided to stick this in here, that when they ask you to do an operational plan, when you start in public health, all right, Ms. Judy Hilton, when you go into public health and they ask you for an operational plan, these are some of the things that they're expecting you to be able to know from your MPH.
Thank you.
Yes, it was a rude awakening for me, and I thought, well, listen, being a part of speaking about family health for the MPH, you need to know about the family if you're not doing the health management section. All right, so time is now running on us. Good. So let us talk. We spoke a lot about the integration in Jamaica. For example, for the primary care services, we spoke extensively on the primary care service. We made mention of Ms. D, who was pregnant, 7 months pregnant, and had to have her antenatal. And then she discovered that she had sickle cell disease, and that placed her in the high risk category. We thank Miss Cindy Peart about sharing her experience, her journey of being high risk. And we want to congratulate her that even though she was high risk, she was able to have her babies, because that is a very fragile period. All right. We spoke to having skilled workforce within the various institutions and the referral system that needs to be in place for this integration to function. We spoke about the various care and services that can occur at the various sites, including nutrition. Right. Ms. Pear has told us and spoke to us about nutrition, the immunization, and having with a well-child visit, having postnatal care, at least all at the same site. So what we have done in Jamaica is that when you have the postnatal visit, normally after delivery, mommy, Ms. D, will have to go to a postnatal clinic. When she goes to postnatal clinic, she not only will have herself being examined, but she will be offered contraceptive choices. All right, that is important, that she will have to offer contraceptive choices. In addition to that, immunization happens at the same visit. Huh? Very good. Huh? You see what I'm talking about? Immunization happens at the same postnatal visit. In addition, babies examined to ensure babies achieving the milestones, where we have the well child being occurring at the same time, babies examined. And so it's really, I think, is a real model. I'm just happy with this integrated approach. It means that we'll have more persons receiving service and quality service, efficient service. All right. And so we'll be able to deploy the workforce in the appropriate way. So we have now not only the regular antenatal and postnatal, but what we have is integration of the prevention of mother-to-child transmission being included in the antenatal services. All right, my alarm is off. So what's important is that we have to have significant improvement in institutional delivery rates and maternal mortality reduction. All right. So we move straight into the details of integrated care. One area that you saw integrated care is our maternal record booklet. This is a patient-held instrument, patient-held friendly tool. And you see we place daddy there, so it's not only maternal and child health. And it has 4 pregnancies inside Miss Pear. It also has where they have dental, must be seen by dental, by nutrition, have blood donors being discussed, pregnancy complications discussed within this handheld document. And most importantly, they have the Act Now, where it tells when mommy should seek urgent medical attention. All right. In addition to that, we have our physical activity and pregnancy guide that we would show mothers what to do and when to do it, right, Mr. Alex Lawson, our physiotherapist. We have this that actually they work with. For physical, the Lamass classes, we're looking for primary care, physiotherapy in primary care. All right, you will hear more about that. So we're looking for healthy mommy, healthy baby, and happy family. That's the target. So we have the integration of care in Barbados, where we have the polyclinic. And you remember St. Vincent telling us about their polyclinic, where they offer comprehensive maternal and child health services. And it's similar to Jamaica, as was discussed. The area here, though, is that is an interdisciplinary approach where we have collaboration across the specialties, across the scale. And so that actually helps in the care integration for the care offers. And so we look quickly here at, I'm just going to ask you if you can please give me 3 more minutes. Is that okay?
Okay.
Yes, Dr. Lord.
Thank you. Thank you so much. All right. So this is here we have, when I spoke to you earlier about the indicators, maternal health being a very important indicator for the country. And this is where we have our maternal mortality trends. You will hear more about this within another section of your classes. But just know that as we have seen, the maternal deaths, well, you know what happened in 2020, 2021, right? Everyone know about that? Yes, thank you.
Yes, ma'am, we all do.
Yes, COVID did us bad. You hear? And this is what it is showing us here. But to know that when you see something like this, when you see something like this, You want to know what is happening with this yellow line here? What is happening with this yellow line?
Less births
We're
over the
showing a
years.
decreasing trend.
Yes, and we don't want that. So when I was listening to Miss Pear, when I was listening to Miss Pear, Miss Pear, twin and the twins and her twins and that she brought, I was very happy, you know, because we want more babies, right? We don't like this. Because with the decrease in birth mean the denominator for maternal mortality. You've completed that already? You did maternal mortality already? You did mortality generally already? All right, not certain. Am I still online? Okay.
Yes, we
Yes,
spoke
you are.
on
Yes, you are.
different sessions. We didn't have one session on maternal mortality, but we've spoken about it in multiple classes.
Okay.
Calculation, yeah, primary health care.
Calculations. All right. So this means the decreasing number of live births, which is the denominator in calculating maternal mortality. It means that this will, even though the number of deaths, you realize it's only the COVID that sent our deaths high, the number of maternal deaths have remained constant. But our maternal mortality, because of this, the denominator, which is the live births, because that is decreasing, it will increase our maternal mortality figure. And it's only when you see it like this, then you realize, it's not really the number of deaths have been increasing, right? So we're still within the 30 to 40 number of deaths, except during COVID. So this tells us about our delays. The 3 minutes is up. All right, tells us about the delays. I won't go into detail, but you will have this as your slide. Delay 1, 2, 3, and 4, which is important. Delays from mommy not being able to recognize that she was a problem, and that's why we have the maternal record book. So the delay 4, the policies and practice within the health facility, as well as the resources within the health facility being limited. So those were actually the causes of those maternal deaths that you would have seen in this area here. So we want to, we see here, also for Trinidad, we see that improved early detection can manage high-risk pregnancies. In fact, they have actually had some very good practices that we would want to also implement here. And so what are some of the barriers to integration? We have the health system challenges that we will have to work through. All right, the workforce issue that we will have to address, the data and technology gaps. You know that those who work in immunization will come to recognize that, listen, we have a mobile population, that when persons come to Kingston and they have their BCG done, when they return back to St. Anne's Bay or to St. Catherine, and they're looking for their baby, they can't find it. And so the data management is very important. The electronic system is what we see after, and that is what is that is what is needed. All right. So we see that is multi-sectoral collaboration and referral and tracking system. That is why we have registers within these health institutions. And the registers is what will actually help in the integration process. All right, because if a mother does not turn up for her antenatal care, we have our community health aides that will go to visit her. And so here's where we have the tracking with health records. And where do we want to go? We want to ensure that we have strengthening of the policy implementation. We want to invest in a workforce training so that everyone will be on the same page. And I'm very happy that we have this as part of the MPH program, that everyone can be on the same page, that when you go out into the field, you know where and when and how to refer. We want to expand the role of the community health aide, and they have actually revised the community health aide curriculum, and now in the process of having a job description so that we can have more contact with our patients. All right, so it's very important that we have an integrated maternal and child health service because it improves outcome. It addresses the fragmentation of the service because we want a holistic service. And I think one of the ways that we can really help as we move forward with integration is really having the digital health system and to ensure that we have proper governance. That's very important. So that's all. Any questions? Thank you for the extra time you've given. We started a little late, but that's it. Any questions? Any comments?
I enjoyed the presentation.
Thank you. Thank you. This is
Cindy.
all right.
That was Cindy.
Oh, thank you. Oh, Nurse Johnson. Okay. Thank you.
No,
thank
that
you.
was Cindy.
Cindy Pear. Oh, yes.
That
Oh,
was Cindy Pierre.
yes. I really thank you for opening and sharing your journeys. Was really, encouraging. Thank you so much. Thank you, Miss Cindy. All right. If there's no other questions or
That
comments,
list of that list of health centers that you had showed with the different designations, locations, etc. Would you be so kind as to share it with us?
Akeem,
Would it be
sure.
available?
You're new. All right. Yes, sir. I will email that to the team that you can have that. I agree. It's something very handy to have.
Yes, thank you.
Any other requests? All right. Thank you so much. Thank you, Mr. Sebastian, for assisting us. Thank you so much. All right. So we meet again in January, the 6th of January.
Okay.
Okay. Thank you, Dr. Lord. Take care.
Thank you, Dr. Lord.
Yes. Thank you. Thank you.
Thank you, Dr. Lord. Thank you very much, Dr. Lord.
Oh, yes. Okay. You're welcome. You're welcome. All right. I forgot that again. All right. Bye, all. We don't have to think about the system running out on us and on stable internet anymore. All right, then. Goodbye, bye, all.
Bye.
Merry Christmas when you come.
Bye.
Bye.